Typical symptom of pulmonary pneumonia: double check, cough, sweating, radiology change, upper pulmonary occasion, dyspnea, fever, radiological changes, lower pulmonary occasion, or can be pulmonary pneumonia is an infection that inflames the air sacs in one or both lungs. The air sacs may fill with fluid or pus, causing various symptoms. Typical symptom of pulmonary pneumonia can be cough, which may produce greenish, yellowish, or even bloody mucus, fever, sweating, and shaking, chills, dyspnea, shortness of breath, and rapid shallow breathing. Radiological changes: pneumonia can often be diagnosed by a chest X-ray or CT scan, which can show areas of opacity wide in the lungs. Location: pneumonia can affect one or both lungs and can occur in any part of the lung without respect to the upper and or lower lobes. So both option A and B you provided can be seen in cases of pneumonia. However, it's important to note that symptoms can vary greatly from person to person, and not all people with pneumonia will have all of these symptoms. Some people may also experience other symptoms such as chest pain, fatigue, loss of appetite, and confusion, especially in older people. Pneumonia, a summary of it, commonly acquired pneumonia, typical pneumonia, streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, Klebsiella pneumonia, Staphylococcus aureus, atypical pneumonia, Mycoplasma, Chlamydophila, Legionella pneumonia. Hospital-acquired pneumonia, primarily from negative bacteria like Pseudomonas aeruginosa, Actinobacteria sp, and Enterobacteria along with Staphylococcus aureus. Clinical presentation: typical pneumonia, sudden onset, fever, malaise, productive cough, crackles, bronchial breath sounds on auscultation. Atypical pneumonia, gradual onset, dyspnea, unproductive cough, subdued or absent auscultatory pumps. Finding: diagnosis, chest X-ray, show lobar consolidation in typical pneumonia, diffuse infiltrations in atypical pneumonia. Laboratory tests: blood culture, sputum, gram stain, and culture, urinary antigen test for Legionella and S. pneumonia. Management: empiric antibiotic therapy, CP outpatient, previously healthy, no antibiotic use, macrolide, azithromycin, clarithromycin, or doxycycline. Comorbidities or recent antibiotic use: respiratory fluoroquinolone, quinolone, levofloxacin, moxifloxacin, or combination therapy with a beta-lactam, amoxicillin, clavulanate, cephalosporin, plus a macrolide. CP inpatient, non-ICU, respiratory fluoroquinolone or a beta-lactam plus a macrolide. ICU, beta-lactam, ceftriaxone, cefotaxime, or ampicillin, surfactant plus either azithromycin or respiratory fluoroquinolone. HAP, empiric coverage for MRSA, vancomycin or linezolide or Pseudomonas piperacillin, tazobactam, cefepime, or meropenem. Supportive care: oxygen to maintain adequate oxygenation, fluids for hydration, and to maintain hemodynamic stability, antipyretic acetaminophen or NSAIDs. Preventive measures: pneumococcal vaccine, PCV 13 and PPSV 23, and annual influenza vaccine, smoking cessation, and hygiene complication to monitor respiratory failure, sepsis, pleural effusion. Key point for exam preparation: understand the difference between typical and atypical pneumonia and their respective pathogens. Familiar with first-line antibiotic choices based on clinical setting and patient's history, and recognize the importance of supportive care and preventive measures in the management of pneumonia and possible complications and their management. Empirical antibiotic therapy: CP, azithromycin, macrolide, doxycycline. Comorbidity of resistant antibiotic use: respiratory fluoroquinolone, levomoxi, beta-lactam, amoxi, clavulanate, cefodoxin, CP inpatient, fluoroquinolone, beta-lactam. ICU, beta-lactam, ceftriaxone, cefotaxime, ampicillin, surfactant, azithromycin. HAP, empiric coverage for MRSA, vancomycin, linezolide, Pseudomonas piperacillin, tazobactam, cefepime, meropenem. canonises gestic rate, respiratory tertiary broad cultures, drums, taking culture, music, urinary antecedents, legionella, pneumonia. Okay, etiology and the CP and HAP. Typical pneumonia, sudden febrile malaise, productive cough, crackle, bronchial breath sound, atypical gradual dyspnea, unproductive, subtle or absent of cultivatory finding. CAP, strepto, hemo, moraxella, Klebsiella, staphylococcus, and atypical mycoplasma, chlamydia, legionella. HAP, Pseudomonas aeruginosa, Enterobacteria, Acinetobacter. Typical symptoms of pulmonary pneumonia, cough, sweating, dyspnea, fever, oral, physiological change, low primary rotational performance. Pneumothorax, above vesicular sound and percussion sound, physical examination finding, unilateral, decreased absence lung sound, hyperresonance in percussion, and decreased tactile parameters. Pneumothorax. Unilateral, decreased or absent lung sounds, decreased due to presence or air in the pleural space, which interfere with the transmission of sounds from the lung and to the chest. Hyperresonance on percussion when the chest wall is tapped percussed. Pneumothorax can cause a hyperresonance sound. This is because air resonance more than solid or fluid field structure decreased tactile parameters. Tactile parameters refer to the vibrations that are felt by the hand on the chest wall during the speech. These vibrations are usually decreased in pneumothorax because air in the pleural space dampen the transmission of vibration from lungs to the chest wall. So pneumothorax, unilateral, decreased absent lung sound, hyperresonance in percussion, decreased tactile parameters, unilateral decrease or absent lung sound, hyperresonance on percussion, decreased tactile parameters.